Good afternoon, ladies and gentlemen, and welcome to our webinar on advantages of synthetic biomaterials in dental surgery and on the topic of delayed immediate implant placement and direct soft tissue management with CERASORB Foam and I and A-PRF. My name is Florian Früh. I'm heading the global product management at Curasan AG. And today with me is Dr. Haki Tekyatan, dentist and specialist in oral surgery from Simmern in Germany. If you have questions, please write your questions in the chat box. We will answer them at the end of the session. And if you intend to gain CE points, please log in and watch the entire webinar before attempting to take the CE quiz. Once you have watched the webinar, then please log into the website again, take the CE quiz and print your CE certificate. The webinar obviously will be streamed, recorded, and then shared online and via social media. And we have made a dedicated case report available to you that will be shared on ZWP Online. I would like to start giving you a little insight on the advantages of synthetic biomaterials in dental surgery. We're talking about CERASORB Beta TCP. According to our opinion, CERASORB is really the first choice when it comes to synthetic Beta TCP bone regeneration materials. The polygonal broken CERASORB M morsels incorporate a 65% porosity in order to allow for a natural ingrow, resorption, and regeneration of the bone. The primary CERASORB M particles form a grid which is interspersed with an interconnecting channel system of micropores through which blood components and body fluids can then enter the interior of the granules by capillary forces. And this serves both cell nutrition and hydrolytic dissolution of the material, both from the in and the outside. In addition, it promotes pervasion of the material with blood vessels, cells, and callus bone. CERASORB M is a purely synthetic bone regeneration material with a phase purity of over 99%, which is referenced as the global ICDD standard for synthetic bone regeneration materials, meaning that every bone regeneration material, synthetic bone regeneration material that comes to market is tested against CERASORB. And since it's a purely synthetic material, there are no infection risks with CERASORB, since it's neither containing any biological residues nor nanoparticles. CERASORB M contains a well-designed and defined microporous sintering structure that avoids particle breakup when it is used correctly. The primary particle size is below 63 microns in order to avoid phagocytosis and in order to be aligned with a natural bone resorption and remodeling ratio. The micro, meso, and macropores of the CERASORB M provide a fast integration of vital cells, a very high release of calcium ions during resorption through hydrolytic corrosion, and contribute to the transformation of osteoblasts to osteocytes. And due to this fact and due to this release of calcium ions, we can really say that our CERASORB M material is bioactive and osteostimulative. Already in 2002, we have tested the material versus a lot of different competitive materials. And we have seen that in comparison to other materials, as well as in comparison to autologous bone, CERASORB showed a very high density of osteoblast formation and a remarkably high performance versus autologous bone. And if you consider the sintering structure and the surface of the material, then it is clear why. The sintering structure and the surface of the material is really ideal for cell ingrowth and on-growth. We have incorporated in our material micropores that are bigger than 10 microns, mesopores between 10 and 100 microns, as well as macropores smaller than 100 microns, in order to trigger the osteoblast formation inside and outside of the material. As you can see in the histological findings, and those are histological findings that have been published in German Journal for Oral Implantology by Planck and Lederer in 2005, you can really see that CERASORB granules, they trigger an active bone remodeling with osteoclastic as well as osteoblastic activities. We can also see that the CERASORB granules are partly resorbed and then remodeled into autologous human bone. The next pictures, also from this histological series, you can see in picture A the beginning ceremolysis and bone matrix substitution. In picture B, the resorption from the inside to the outside, meaning that you have a bone building in the center of the granule. Picture C, resorption from the outside to the inside, leading into a central building of osteons. And finally, in picture D, the complete new bone in erstwhile granule CERASORB structures, where you only see a hull of the CERASORB. Our CERASORB M material has then been designed and developed into a collagen composite material, CERASORB Foam, which is a multiporous material made from type 1 porcine collagen and pure phase beta TC granules of different sizes and densities. The granules are embedded within the collagen component and fixed by the collagen fibers. CERASORB foam has particularly user-friendly properties because moistened with blood from the defect or mixed with autologous thrombocyte and fibrin concentrate, I and A-PRF, the material can be really easily modeled and inserted into the defect precisely and comfortably. The large contact area with the surrounding vital bone allows bone-forming cells to tap into the material and also facilitates the absorption of nutrients, proteins, and other growth factors. In addition to that, CERASORB foam is an ideal scaffold for various antibiotics, and this claim has just recently been approved by Khorasan's legal notified body. The special CERASORB foam collagen matrix further ensures a high level of volume stability after the collagen, which is more rapidly absorbed, has been broken down, and the high porosity of the granules in turn offers the newly forming bone a stable framework. CERASORB foam comes in a highly moldable and flexible version, allowing the surgeon to adapt to the given surgical defect situation at any time and any circumstances. The foam is completely broken down and thus replaced by autologous healthy bone. And now I would like to pass on the word to Dr. Haki Tekyatan from Zimmern in Germany, who will present us cases on delayed immediate implant placement and direct soft tissue management with CERASORB foam and I and A-PRF.
So, I hope you can hear me. Dear Mr. Früh, thank you very much for your nice presentation and also for the friendly introduction. Dear ladies and gentlemen, dear colleagues, welcome and thank you very much for participating at this webinar. I hope we will have an interesting and informative time together. First of all, of course, I would like to thank Mr. Free for all his efforts, for all the support in the last time. It is really great for me. And I'm looking forward to all our following projects. I'm really happy for that. And of course, I would like to thank Kurasan, Ömos Media, CVP, all the technicians for giving me the opportunity to carry out this webinar here. I really feel honored. The title of my presentation today is Delayed Immediate Implant Placement and Direct Soft Tissue Management with CERASORB Foam and I, A-PRF. Edmund Hillary said, "It is not the mountain we conquer, but we conquer ourselves to achieve and to go on for goals, trying to be successful, to keep on developing, and of course, to keep our minds open for new methods, new therapy options, and new materials. This is the credo of our dental clinic." When we talk about mountains, I'm living in Simmern, a town in Hunsrück in Germany. It's a well-known place in the mountains. I have my dental clinic here on the right side, you can see there. And here you can see our so-called Schlossplatz, our marketplace. It's a beautiful city to which I would like to invite you. About me, my name is Haki Tekyatan. I'm an oral surgeon and dentist, and I'm specialized in implantology and periodontology. The aims of my presentation are: how can we support the alveolar regeneration after extraction? I would like to present you a protocol for this mentioned question, and I would like to present you cases that we treated with CERASORB foam. Nowadays, our patients, but also our colleagues who refer us patients, are expecting from us implantological success. But we have to say, and however we can say, that surgical or functional success is not enough anymore. More and more aesthetic success is also expected, and maybe the most important factor in our implantological daily life. In order to be able to guarantee this to our patients and to our referring colleagues, of course, we need sufficient and adequate bone and soft tissue conditions. Why sufficient? Why not just, for example, quantitatively enough? I would like to introduce you and to discuss that with you in my presentation today. In implantology, we have to deal with many important aspects, from the planning to the implementation of our implants. And in order to achieve our goals in implantology, taking into consideration the interface with biology is very important, as we all know. Different methods and materials have been used for many years to preserve tissue, or, as we currently better have to say, to support the regeneration. These methods are, for example, the socket seal, alveolar preservation, ridge preservation, and different methods of socket preservation techniques. What I would like to present you today is the method of the socket preservation with CERASORB foam in combination with delayed immediate implantation by means of two clinical cases, one case with PRF and one case without PRF. We all know the histological study by Araujo, which was published more than 15 years ago. In their investigation, they could prove that despite of the limitations of this study, that we have resorptions, as you can see here. Interesting is that we, after 2 months, the study shows a significant resorption of the bone, and the buccal bone decreases more than the oral bone. Many studies deal with the question of the dimensional change of the bone after tooth loss or extraction, as for example by Yang, Tan, Schropp et al. And if we look to the available data, we can see that the horizontal bone loss is in general more pronounced than the vertical bone loss. In the coronal part, we have more bone loss horizontally than in the apical part, and tooth extraction without the use of grafting material leads to a percentage of horizontal dimensional changes up to 70% after 6 months. In millimeters, we have a horizontal bone loss about 3.8 millimeters after 6 months, and a vertical bone loss of 1.2 to 1.5 millimeters after 6 months. A systematic review and meta-analysis by Avia Ortiz et al. Shows us that alveolar ridge preservation methods are very effective and successful in reducing physiological ridge resorption. When we come to the conclusion, of course, dear ladies and gentlemen, volume stability is important. But from a biological point of view, vital and a high quality, good but vascularized bone for implant therapy should also be an important aspect. We know from the literature that a total volume stability is not possible. We always have more or less resorptions. In this context, we maybe have to rethink about everything. This is not just only my opinion. If we look to the current state of medicine, not only in dentistry, biological and regenerative materials and methods are coming more and more into focus. So we have to say, and maybe to realize, that in modern implantology, we need materials and methods that support the bone regeneration, not only preserving the volume. The material that we use in our dental clinic is the CERASORB foam. And as Mr. Free has already presented you in detail, very nice, it is a new type of bone regeneration material. It is made of 85% beta-tricalcium phosphate, 15% porcine collagen, specially prepared and structured. In this context, I would like to show you a study from a research group by Professor Palm, Professor Grötz, and Rupp et al. It is a split mass study. 39 patients were included in this investigation. Controls were made after 1 week, 1 month, and 4 months. Clinical investigations were made, X-ray and histologies were also made. They had 5 dropouts in their study. And 3 months after augmentation, biopsies were taken and examined histologically. On this histology, we can see our spongeous bone. We can see some fat inclusions. We can remains of some bone substitute materials, compact bone, and so on. We see a lot of new bone, but what is here very, very special? What is the interesting thing that we see in the study? So let's go into the detail. We see after 3 months, lamellar bone and a high degree of mineralization, as you can see here in the orange colored area. We know from the bone biology that lamellar bone normally develops after 6 to 8 months. And this is very special in this study. They were also able to prove that CERASORB foam preserved histologically and radiologically more bone than in the comparison group. But why is this so? It seems like in this study that because of the special matrix structure of the collagen and the beta TCP and the ability to release calcium, CERASORB foam improves and supports the bone regeneration. And this is exactly that what we want. Of course, this assumption needs further scientific research and evidence, but in my opinion, this is a very important argument for the regenerative potential of CERASORB foam. And with this knowledge and this background, I would like to present you 2 cases. The first case, as you can see here, is an endodontic failure on tooth 1-5, as you can see. Here you can see the vertical aspect. Here you can see the view from the buccal. I have prepared a video of this case for you to show you how we proceed when we do an extraction and try to preserve our tissues. We always try to protect the tissues. We work with special instruments, periotomes. In this case, for example, we worked with the Clark instruments developed by Karl Ludwig Ackermann. The soft tissue is detached very carefully on every side. This video runs a little bit faster because of the time. There you can see that the crown fractured. And sometimes we have to do an osteotomy. And this shows us very nice. It is very important to do that everything internally. We try in our clinic to avoid a buccal flap, and so to avoid resorptions, then careful removing of the fragments. Here you can see now the part of the root that we remove. Then cleaning and curating of the socket. This is something that we often do in our clinic with the microscope. And this is also a very important step to keep the risk for infections as low as possible. So you can see the CERASORB foam. We can cut it into pieces, and then we put it an apical part of the CERASORB foam, and then a crestal part. It's very important in this step to work with gentle pressure and to try to fill completely the socket, but not to try to destroy the structure of the CERASORB foam, and then everything stabilized with a simple crossed mattress suture. So here you can see the X-ray after extraction. Please notice, dear ladies and gentlemen, how homogeneous the material is radiologically. It seems to almost identical to the surrounding bone. This is something that I always find very interesting. Here on the right side, you can see the condition 2 days later. Now, 2 weeks later, here from the buccal view, please note the stable contour of the tissues. And then 6 weeks after extraction and before implantation, we still have very stable and nice conditions of the soft tissue. Previously, we carried out our implant planning using a DVD cone beam. And also here you can see the structure of the bone and the planning of our implant. And now you can see the pictures of the implantation. On the left, very nice. We have after flap preparation, very nice bone condition. On the right, you can see the initial drilling, then the determination and checking the inclination and position of the implant. Right, you can see the implant placement. We like to bring the implant into the final position with the ratchet. And then here, the inserted covering screw and the suture at the end of the treatment. And here you can see the post-operative panoramic X-ray. You can see the placed implant, the position of the implant. This case, dear ladies and gentlemen, is a current case. It's still in the healing period, so that the documentation for this case ends here. So let's come to our second case. This is a case of an extraction 1-2 after post-fracture of a root canal treated tooth, socket preservation with CERASORB foam and activated with A-PRF. The A-PRF, or low-speed centrifugation concept developed by Professor Sharam Ganati from the University of Frankfurt, is meanwhile a concept that is a very biological method that we regularly use. We have very good experience in terms of wound healing, pain reduction, regeneration support. I don't want to go to further details here. I can only say that an evidence-based guideline by Professor Ganati's group is about to be published and will bring, I'm sure of that, a lot of scientific clarity regarding the topic of blood supporting methods. So here you can see the status in the overview, the tooth 1-2 before the extraction. And here the same, the careful removal of the fractured tooth. On the right, the removal of the root fragment. Then previously blood was taken intravenously and then centrifuged according to the LSCC protocol from Professor Ganati. Injectable PRF was applied to the CERASORB foam, and you can see how wonderful the CERASORB foam takes the A-PRF, and the perforation is working here very nicely, and then thereby biologized or biologically activated, placed into the socket with careful pressure. Here you can see from the vertical view after placement of the activated CERASORB foam. At the right, you can see the A-PRF plug that has already been prepared meanwhile by our assistants. On the left, the prepared materials. On the right, how the plug is placed on the activated foam. And then a final cross suture on the right, the temporary restoration in the base designed as a Pontic. And again here, the post-operative X-ray of the extraction. Also here, please notice the structure that CERASORB foam shows in comparison with the surrounding bone structure, which I said before, it's always, for me, very interesting to see that. Then at the left, you can see 1 week after extraction. At the right, 2 weeks after extraction, non-irritating conditions, very nice clinical situation before implantation. Here you can see the case after 6 weeks. Previously, also here, comb beam planning was carried out and an implantation guide was planned and produced. Here you can see the planning of the position of the implant, here the guide. And here you can see in the implantation the placed guide, the implant placement at the left side, and vertical view of the implant in the final position. A scan body was placed intraoperatively and the situation was scanned before suturing. As you can see on the right, the scan images that we have made during the implantation. And yeah, I have also prepared a video for you of this case, which I would like to show you. Here you can see the clinical situation, maybe some rests of the CERASORB. This is absolutely not a problem. We made a metacrestal incision in preparation of the flap to have the access for our implant guide. And then the implant guide placed. And starting with our drilling protocol, here the initial drilling. And then I'm jumping over to the final step, the final drilling, to go to the depth. We planned here a 3.8 diameter and 13 millimeter in length implant, harvested some bone. Then the implant placement, everything guided to have the right position. This all with 15 Newton centimeters. But what I'm still everything like to do is to work with the ratchet and to find the final position manually. Then removing of the insertion post, removing of the guide. And sometimes it feels difficult for me to find out the position. I like to replace the guide and then remove the guide and then replace the insertion post again. This is because of me, because I want to see clinically again, the last and the final situation of the implant. Here you can see from the vertical view. And then cleaning everything, preparing everything for the scanning process. Then we are placing our scan body. Very important to find the right position. And then we are starting with our scan process. First of all, the upper jaw, then the lower jaw. And then what you see here is to match the occlusion so that the both jaws and the both scans can be matched together. And then we have all the informations we need for our final restoration. That means we have no impression. We do not lose any time. We can go on with our further steps. Here, removing the scan body, placing the covering screw, then the previously harvested bone, some augmentation, just as resorption protection, I would like to say. And then our suturing by using special techniques from the periodontal surgery. So here you can see the final situation after implantation. Here you can see the post-operative panoramic X-ray and the position, the final position of the implant. And the nice thing here is, while the implant is in the healing period, with the information of our scans, a special new type of a healing cap or sulcus former was made entirely from PEEK, polyether-ether ketone plastic. And after re-entry, the healing cap was already there, it was placed, and we could start with our soft tissue management immediately and directly after re-entry. And also here, suturing techniques from the periodontal surgery. Here you can see the PEEK, and here the planning of the PEEK healing cap. After 3 weeks, you can see this picture of the soft tissue conditions. Please note the buccal contour. Above all, the very nice and individualized structure that we can see here. Absolutely no irritating conditions. Here you can see the final view of the final crown restoration here too. Completely non-irritating conditions of the soft tissue. There is still a lot of potential in the soft tissue, and we expect further positive remodeling of the papillae here. We are continuing to monitor and to follow up this case and updating the clinical status. And then here you can see our X-ray image, very nice bone structures that we can find here. So, dear colleagues, we are at the end of my presentation. It was really a great pleasure for me. I hope you could enjoy our presentations. Looking forward for your questions, and thank you very much for your attention.
Thank you very much, Dr. Tekyatan, for this outstanding presentation of your experience and of those cases.
You're welcome. Here is a question. Can you share with us, Doctor, the slides? Does somebody wants to? Okay.
How long does it take the CERASORB foam to change to bone completely? Dr. Tekyatan, I leave this question up to you because you have the clinical experience here.
Yes. I can say when we do the socket preservation with CERASORB foam and when we do the delayed immediate implant placement, we still have rest of the bone substitute material. We still have rests of the beta tricalcium phosphate. But this is something that I personally really like because we have our bone, we have our regeneration, and we have our initial bone. We're placing our implant into a structure that still is in the healing, still is in the regeneration. And I would say after 3-4 months, we have a very stable situation. But even though, when you're looking forward, there's still a remodeling process. And this is very interesting for me to see that. I think it has something to do with the calcium that CERASORB releases. But I would say about a half year, the process should be ended. What the change of the CERASORB means.
And I can underline this from scientific aspect. There are many studies out there that prove that CERASORB foam and CERASORB is completely and evenly resorbed and remodeled into human autologous bone, depending on the defect size, within 6 to 12 months, both in the dental surgery as well as in the orthopedic and trauma surgery. Dr. Tekyatan, this question goes to you.
Yes.
About your implant placement and how often do you use?
your implant placements is 6 weeks after the exo and graft. I think we're talking about the extraction. And how often do you use PRF? I can say that I'm using PRF in any implantological case, in any. If there is an implant planned, I'm using it. This is something that I'm very convinced of.
CERASORB granules are FDA approved in the United States, and we are just undergoing the trials for FDA approval of the CERASORB foam.
As I said in my presentation, the torque that I use is about 15 Newton centimeter, but sometimes I can go to 20. I can go, if I want to. We have some cases that I directly restore with a provisional, and I'm doing some bone training for 6 weeks. And in these cases, I'm even going to 30 or 40, sometimes 50 Newton centimeter. This is absolutely not a problem. But in normal cases, I have 15 to 20 Newton centimeters. And as I said, the final position manually. This is something that I really like and still have to do. It is okay to have the machine and to have the implant center and to work with it, but I need always the last feeling of my hands to say.
Are there more questions from the audience? Very good question. Dr. Tekyatan.
This is something that I wanted to say in my presentation, but I'm sorry for that I didn't say that. I'm very surprised how hard the bone is. Normally, after 6 weeks, when I don't use any supportive materials or regenerative materials, it is not so dense. But in these cases where I use it, especially in combination with the PRF, I have the feeling that it's more dense. It seems to be some kind of faster developed in the healing. It sounds strange, but the bone is much more harder than I every time expect. I have cases with buccal defects, and these are some cases that I want to present you the next time. In this, okay. Okay, how do you manage buccal defects with this product? We are using this product also for lateral augmentation. In this case, I'm doing a combination of CERASORB foam, and I'm working with sticky bone, combination of PRF, own bone, CERASORB foam, and also A-PRF, and then placing a guide. In many cases, I'm working with the OS guide. It's a resorbable collagenous membrane that I then use. And what I do not make is some kind of open healing, what you can see in the literature when we do ridge preservation techniques. I'm always interested in to have a dense suturing of the situation. But then I'm working with a membrane. The PRF or the CERASORB foam. I have to say that I have no experience of with CERASORB foam in the periosurgery. Can you say something about that, Mr. Früh?
We do have cases in periodontal defects that are also published. It is also working for periodontal defects, but at the moment I don't have the cases here to show. Surely we can include that in our next session. When did you place your final restoration? 9 weeks after the extraction, question mark?
No, we made 6 weeks after the extraction, the implantation, and then 6 weeks later, we placed the healing cap, and then 3 weeks later, the final restoration. Have you used titanium mesh with this product? I haven't used titanium mesh with this product, but I know that there are cases.
Yeah, we do have cases with titanium mesh, especially for larger defects, lateral augmentations that are used by Professor Ganati in Frankfurt. It's a combination of CERASORB foam, also granules, sticky bone, and the mesh, titanium mesh products. Is CERASORB foam good in ridge augmentation where you don't have much bone surrounding or a very thin ridge, Dr. Tekyatan?
I have cases where I used it for the ridge augmentation, and I have successful cases. As I mentioned before, we are doing it in a combination with sticky bone, CERASORB activated, bioactivated CERASORB foam using membrane technique. Sometimes I have also cases where I use the bone shell technique, according to Professor Khoury, and then filling up the gaps with CERASORB foam or sticky bone sticky bone. And I have, in all the cases, quite a good experience. And in these cases, I'm using it, yes.
There is another question. How would you compare CERASORB versus xenogene material, such as BIOS, for example, from a regenerative standpoint?
How can I say? When I look to CERASORB foam, I have the feeling that there is a lot of potential concerning the regeneration. I think there are some studies who tell that BIOS also can release calcium, but I think that CERASORB foam and CERASORB M, for example, has more potential for the regeneration. And when I'm trying to do regeneration, I'm using CERASORB foam.
This may have been asked, but can it be used when you have a loss of buccal cortical plate to rebuild that bone in conjunction with a membrane, Dr. Tekyatan?
Yes, I'm using it. In these cases, I'm using it. And maybe I'm preparing a specific case. Maybe I can show you that and publish that. And this is a case that I will show in Frankfurt in 2 days. And I'm using it in these cases, and I have a lot of success with that. Yes.
How long do you wait for the ridge augmentation before placing implant? Also 6 weeks?
This depends on the case. In some cases, when I know before extraction, it is important what I'm doing before. For example, I'm doing an extraction, and it is we can see, or we can expect, that we will have a buccal defect, or we will have a transversal defect, and implants, our patients wish implant, then I'm doing the ridge augmentation even directly after extraction. And when we, for example, extracted the tooth and ridge augmentation at that time is not planned, we can wait 6 weeks, but we also can wait 3 months. And we also can wait 6 months. It depends on the patient. I think that there is no time limitation. When we have the opportunity and when we can do that, we are making our augmentation, even after extraction, immediately.
How about in vertical bone loss in placed implants? Is this a product to be used?
I never used it for vertical defects or surrounding defects on implants. I have no experience in that. I cannot say, but I can imagine that it works.
Yes, I can underline that it works. We have surgeons who are using it really around the implants in order to fill the gaps, and especially the foam works pretty well in those cases, because once hydrated, it can be easily molded and placed gently into these defects and gaps around the implant. Okay, I can see that there are no more questions at this moment. Dr. Tekyatan, thank you very much for your outstanding presentation today. It was a pleasure to hold this webinar with you today. Thanks to the audience, to the attendees, and also to ÖMUS, DT Study Club, and ZWP Online for making this webinar possible. If you have any questions, please feel free to contact me directly via LinkedIn or info@curasan.de. I'm happy to forward your questions to Dr. Tekyatan or by answering them by myself or our product managers. Looking forward to having you on board for the next webinar, and then hopefully on lateral augmentation with Dr. Tekyatan and CERASORB Foam. Thank you. Have a great evening. Bye-bye.
Thank you very much. Thank you very much.
Liebe Zuschauer, vielen Dank für Ihre Aufmerksamkeit. Sie haben jetzt die Möglichkeit, einen CME-Punkt zu erwerben. Hierfür müssen Sie nur den dazugehörigen Multiple-Choice-Test absolvieren und mindestens 70% der Fragen richtig beantwortet haben. Darüber hinaus bietet unser CME-Bereich vielfältige weitere Möglichkeiten, sich fortzubilden und Punkte zu erwerben.